Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. Today's episode is sponsored by Inito. And my guest today is Dr. Roxanne Pero. Dr. Pero is a triple board certified OBGYN who received her medical degree from LSU Science in New Orleans and subsequently completed her residency at the University of Texas at Southwestern Parkland Memorial Hospital in Dallas. She completed 12 years of private practice in OBGYN and did some infertility where she cared for thousands of amazing women and helped so many resilient families through high-risk pregnancies. For the last 4 years, she has stepped out of the hospital and into the holistic space, integrating her Western medicine knowledge and innovative alternative therapies. She is a diplomat of the American College of Lifestyle Medicine, a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions. She's board certified in functional medicine through the Institute of Functional Medicine and currently has a thriving practice in Dallas, Texas called Alive and Well. Okay, so today's episode, we are going to be talking all about the menstrual cycle. Understanding the menstrual cycle, we're going to take a deep dive into each aspect of it, understanding how to use the menstrual cycle as a vital sign, and discuss the best way to monitor ovulation and the different causes of ovulatory dysfunction. With me today is Dr. Pero. I am so excited to have you here and for us to really take a deep dive into all these different things.
Thank you, Sasha. It's my honor to be here, and I'm super excited about our convo today.
Yes. So we spent a little bit of time before this at the one hotel. It was very vibey.
Yes. So trendy. I shouldn't belong there. Didn't feel like it.
Oh, you totally belong there. But I really appreciate you coming all the way from Texas.
Yes.
So you currently live in Dallas, correct? And that's where your practice is at?
Yes. I went to Texas to train for OBGYN residency at Parkland, which is like
the biggest program in the country.
The biggest program in the country. And it was like, I still have PTSD from it, but it's all good. But I learned so much. And it was exactly the intensive that you need, right, for taking care of two lives, a woman and a child. And then thankfully, I loved Dallas, and so I stayed there and built my world, and I've been there since 2005. Yeah.
Yeah, that's a long time.
Yeah.
2005. Wow.
I still can't say I'm a Texan yet, but I'm working on it.
Where are you from originally?
Louisiana.
Louisiana. Okay. Yeah. And that's where you did med school.
Yes, exactly.
Yeah. Amazing. Mm-hmm. Okay. Well, I mean, Dallas is a really cool city. We almost considered moving there to practice there, but our hearts were in LA, where family is. And so, I'm very excited to have you here.
Thank you.
I know in your practice, you sort of delve in a lot of lifestyle medicine, but also fertility. Can you talk a little bit more about your practice?
Yeah. So, my practice was built on my own personal journey, just understanding that through the 4+ years that I went through trying to become a mother, it felt very one-sided, and it felt very much like I was being worked on as an individual with all of these people around me, but I wasn't actually in the process of it. Every month I got my medications and I got the timing and when I needed to be for my ultrasounds and all of that. And I just kind of felt like a robot, outside of the office. I wasn't doing anything on my own, or at least that anyone had told me to do. And so as I became a mom, and I think especially having children, and then also understanding there's just so much nuance and personalization to a woman's journey to motherhood that it almost got to a point that I just couldn't stop not listening to those voices in my head that were saying it has to be done differently. You can't continue to practice medicine the way you're doing. So with a heavy heart after almost 12 years in private practice, I walked away from the...
That must have been so hard.
It was so hard.
And scary.
So hard. Right?
It's a big part of your identity when you train in a specialty for so long.
Exactly.
Yeah.
Exactly. But I knew intuition at that point had played a big part in my life. So I just had to step out on faith at that point. So, and it served me well. So even though I no longer deliver babies, oh my gosh, I still have so many women that come back to see me after I've delivered their babies. And just this, the trying to conceive part of it is just really where, even though I wasn't trying, I feel like I found a niche that I'm very helpful for women.
Yeah. And what a luxury it is to be able to see your gynecologist who is also able to help you with your lifestyle, help you at least with the early phases of fertility treatments until maybe some people will get to a point where they may need IVF. But in many cases, a lot of couples don't need IVF, and it can be a very scary and really expensive process to go to an IVF center where you're just getting so many different opinions of doing more intervention, more treatment. And so to be able to do a little bit more conservative therapy through lifestyle, ovulation induction, getting it monitored, which, disclaimer, we talked about this before, not every OBGYN knows how to do this well. And so having you as a resource where you understand it, you know how to do it well, they get to utilize you. Yeah. It's amazing.
Thank you. It's super exciting. And just like you said, scary, that's a big part of what I do, as well as I have patients that come to me and they're like, oh, well, I've been recommended to have surgery for endometriosis, or I've been recommended to have IVF. And, it seems like, it's really scary and I don't want to do that. And you're more holistic and integrative. So I want you to tell me something else that I can do. And they might be surprised when I tell them you need surgery or you need IVF. But here's the thing. I'm going to help you to make it not scary. Okay. We don't want to make decisions out of fear. And that's a lot of what women are going through these days. It's like every step of this journey, I hear so often, well, I just want it to happen naturally, and what that really is that you don't want to have to be in the driver's seat, because that's really scary. You want it to happen naturally because you just don't want to have to think about it if it doesn't happen naturally, that it's your fault for some reason. But it's empowerment, it's education. And the more that we have a supportive team on this journey, wow, it makes a huge difference.
It does. And I think the wanting it to happen natural is it's kind of a complex series of emotions between one and to feel like your body's not broken.
Yes.
And then I'm sure for many, there is the financial aspect of it. And then there is the physical aspect. And I also do believe a lot of people think that IVF pregnancies are just inferior to spontaneous ones. So there's still a lot of misunderstanding and taboo and sort of negative connotation that's associated with it. But we are now celebrating over 12 million babies born from IVF, which is insane.
I think today is IVF World IVF Day.
It's World IVF Day. Yeah. It is Louise Brown's 44th birthday. So
happy birthday, Louise.
I know. 44 years since the world's first IVF baby was born. She is lovely. She's hilarious too.
That's what I hear.
Yeah, she's so funny. She's fun to be around. So
it's beautiful. Truly beautiful.
Yeah. So let's get into period stuff.
Yes.
Because I know that a lot of women don't even understand the menstrual cycle. Many even think they do and will use apps. And I want to even get into why apps are not ideal, at least as a sort of one and only tool for monitoring ovulation and tracking your cycles. But let's sort of start with why is talking about the menstrual cycle and really understanding it taboo?
Right? That's a great question. I rack my brain about that often, but I think that it comes down to just how we've evolved as women who want to be on the same playing field as men, So menstrual cycles don't have that opportunity for conversation, We don't want to say, oh, well, I'm on my period, so I'm not feeling the best, or I have to miss this meeting because, I'm having a really bad period day today. So I feel like we've been conditioned to not talk about it. Don't talk about that thing that makes you different from men, even though we know like that can be your true powerhouse when you truly understand your menstrual cycle.
Yeah.
What do you feel like it is?
I think it's that, and I think that part of it is almost shame that can sometimes be cultural. Like, don't tell anyone you're on your period. It's dirty. Like, it's this dirty thing. You're shedding your lining and you're actively bleeding. And so, and I remember being young when I would have an unexpected period at school and I would need a tampon, which I didn't have on me, or a pad. And I would like whisper to the other girls, hey, does anyone have an extra tampon or pad? And we'd have to discreetly exchange it. Or even when I buy menstrual products at the store when I was younger, I would feel so embarrassed if another man saw that I was purchasing this, as if it was an abnormal thing.
Right.
But it is normal human physiology.
Yes.
And it is a huge sign of health.
Absolutely. I've been trying, my daughter's 8 years old, but already we talk about those things, and I put positive, reinforcement on, I'm so excited for you when you get to this point. This is what you're going to experience.
Oh my gosh, I love how you phrase that.
Yeah.
I'm excited for you.
Yes, I'm excited. I'm truly excited for you. And the boys are like, they look kind of like with their eyes wide. And I think that they're starting to get like even just a little bit jealous that it's like something that she's entering into, and they won't have that opportunity. So I was like, that's what we need to do. So
I love that.
Yeah, I want to do like
how empowering.
Make menstrual cycles amazing again. Some kind of slogan.
That's a good one.
We need to figure that out. Campaign that.
I love that.
Yeah.
And she's so lucky to have a mom that's like, you know what, this is so amazing. You're like, this is what's going to make you more powerful.
Yeah, because we all remember our first period. And I would venture to say that probably 95% of us have a negative past with association with that experience. I know for me, I was so ashamed. I was like cheerleading at my brother's basketball game, and it happened. And my mom, put a bag of pads and some little cartoon book in my room. And that was that. That was it, I don't want that to be for her.
Wow.
Yeah.
Yeah, for sure. I mean, I guess I would say unless you're me who's like 16 and you're the only one that still hasn't had a period and you're like, when is this coming? Let's go. And then as soon as I got it, my mom's like, we got to go out for dinner, celebrate your womanhood.
That's awesome. Yeah.
But prior to that, I mean, I remember being 11 and, a lot of my girlfriends at the time, my friends, school friends, they were getting their periods and I didn't even understand what it was. And I went home and I said, Mom, what is that? And they hadn't even taught us that in school yet. Can you believe I'm 11? And I mean, girls are getting their periods much earlier now for, this whole separate topic.
Oh, yeah.
But, then she thought, oh God, we already have to have this conversation. So it was very late. It was very confusing to me. And then sex ed was very underwhelming. Now looking back in terms of the information that was given, everyone is now talking about how it just lacks the education needed to understand ovulatory cycles. Yeah. And both girls and boys should understand it. Men and women should understand it.
Absolutely.
So I'm curious to see how you explain to patients. Do you explain to them how the menstrual cycle works? And if so, how do you explain it to them? I'm always really curious to hear other doctors, how they explain it.
Yeah. Oh gosh. I would say that I probably don't explain it enough, like in a specific way to patients to educate them. But I kind of, talk about it in light of, so I had a patient this week who came in and said that she'd been with her OBGYN. She stopped her birth control pills, which she had been on since middle school, which, that kind of raised, my spidey senses, right? That she had to go on birth control pills for menstrual issues during middle school. Mm-hmm. And she got off of them and she hadn't had a period. And, her doctor said, well, then she finally got a period. It was 45 days after. And her doctor said, well, that can be normal. Different people have periods at different times. And as long as you're having a regular one, so as long as it's coming every 45 days and, it's just, we've lost touch with continuing to educate ourselves, I truly believe, as medical doctors. And by no means do we necessarily have time. We seem to be so overwhelmed with seeing patients, but we have to make it our time, right? Because otherwise patients are coming in and they're teaching us. And so, we talk through what's quote unquote normal, that every 28 to 32 days.
Yeah, I was going to say, let's start with some definition.
Right.
What is a normal menstrual cycle like?
Yeah. And you correct me if I'm wrong. Like, I am humbled. I am always ready to learn. So, yeah. So I say, every 28 to 32 days is quote unquote normal. Okay. Now, the variation, though, can be when you actually have the start of your flow. So some women have 4 days of a normal flow. Some women have 8 days of a normal flow. And those can vary from month to month how long you bleed, but that is still individualized. There's not necessarily anything wrong if you're having a 4-day flow, not necessarily anything wrong if you're having an 8-day flow, as long as it's not impacting, right, your quality of life. If you are bleeding and changing a pad or a tampon every couple of hours, even in a 4-day cycle, that's something that you need to address with your doctor, right?
Yes.
Spotting before your period is something that I think just so many women just accept.
Think, is there a polyp? Are there fibroids? Right. Why is there bleeding intermittently throughout the cycle?
Exactly.
That's not normal.
Exactly. Yeah. But we're, and I always laugh at the word spotting. Like, we use that's like just something cute. You're just spotting, but it can really be something pathological, like you said.
Yeah.
And then, 28 days for me, I've had some doctors that have said, oh, well, even if it's 21 to 34 days, and I don't know what your...
like the ACOG definition is very widely encompassing, which as an REI, for me, I always say, even if 24 days is considered normal, that's really short.
Yeah.
And if it's really short, that raises red flags for me. Like, is your egg reserve dropping?
Exactly.
Or maybe you have a normal follicular phase, and we'll go into what that is, but a normal follicular phase, but the luteal phase is really short, which can make it very hard to maintain a pregnancy. And I do sometimes see that in practice where a woman will ovulate cycle day 16, which is very normal, but then the luteal phase will be 8-9 days.
So 8 days into making progesterone, it just...
And it usually peaks around day 7 post-ovulation. That's where, if you look at the menstrual cycle curve, you see that progesterone is peaking. And this is why we check progesterone levels 1 week after ovulation. And in her case, it peaks beautifully, and then it shoots down to 0 the next day. And so that, to me, is a luteal phase defect.
Absolutely.
And now we need to supplement progesterone.
Absolutely.
And had she not been tracking with her Inito monitor, we would be starting from scratch to figure that out.
Exactly.
And so, and I would be thinking, oh, maybe your ovarian reserve is really diminished. And that would be probably my first thought of what is happening.
Absolutely.
So,
Absolutely.
And for the listeners who don't fully understand, some basic menstrual cycle definitions, I would say most of us agree in the infertility world that anything from 26 to 34 days would be considered normal. So there is some variation there. If it's 26 days and has always been 26 days,
right,
that's great. But if it was 32 days and now it's 26 days, that can alert you to some major changes in your physiology. Your ovarian reserve may be dropping. And so if you're getting older, that would be appropriate, particularly in your 40s. But if you are still young and that shift has happened pretty drastically and consistently, then that might raise some red flags that you have an accelerated loss of ovarian reserve.
Absolutely. Exactly. Yeah. But then you think, oh, well, I'm still having a period every month, so it must be fine.
So I'm fine. Yeah. And on the like opposite end of that, I do see a lot of women who have very regular menstrual cycles, 28 to 30-day cycles every month, and they come to me asking if they're in perimenopause, and just because they're in their mid-30s. And I'm like, perimenopause does not usually start in the mid-30s. Right. It would be an anomaly if that was the case. It is possible, but it is unlikely.
Yeah. Which is just fascinating because there's just like so much talk about perimenopause and menopause now that,
which
we're
is
starting
amazing.
We're starting to have patients like truly ask questions, So that's really amazing. But so a 21-day cycle, so many women that come to me and are having regular 21-day cycles. Well, you think about even those nutrient depletions that are happening. You're bleeding every 3 weeks for at least 4 days, what's going on. And just that diminished ovarian reserve that we see with that too, as well as that association with endometriosis. So, endo being a big culprit to that for sure. Mm-hmm. Yeah. So, and when it comes to understanding the menstrual cycle, so tell me if you would explain this differently. I always say the main four hormones that you need to understand is 2 coming from the brain, 2 coming from the ovary. The 2 signaling hormones from the brain is FSH, follicle stimulating hormone, does exactly what the name suggests. Exactly. It's a hormone that stimulates your follicles to grow, and follicles are containers for your ovaries, for your eggs. And then you have luteinizing hormone, which is responsible for ovulation and maturing the egg so it can get fertilized. Then you have estrogen and progesterone, which are secreted from the ovary. Estrogen helps to mature the egg before ovulation. It also helps to build the lining of the uterus in preparation for pregnancy. And then after that LH surge, your progesterone spikes a week later, and that progesterone rise is responsible for preparing the lining for potential pregnancy and implantation. Progesterone, think progestation, which is Latin for pregnancy. So it's your pro-pregnancy hormone, and that is its role. Beautiful.
And then if there is no pregnancy hormone called HCG to keep that follicle that is producing the progesterone and estrogen alive, it dies off. You get a depletion of estrogen and progesterone, and it's the withdrawal of progesterone that makes you shed your lining. Absolutely. So that is like the most simplified version of how I explain the menstrual cycle.
I love it. You did it so perfectly well.
Thank you. Yeah. Thank you. Any other way that you would sort of explain anything you would add? I guess like the estrogen peaking before ovulation would be one.
About 3 to 4 days before that, you see that LH surge, you're going to have that increase in estrogen, which is where you're seeing maybe increased libido, those cervical mucus changes that we talk to patients about. Just, it's so much body awareness that can go on that's how you start to learn what your hormones are actually doing. Oh, okay, that's estrogen that's doing that. That's progesterone that's making me a little bit more tired and a little bit more craving of dark chocolate and things like that. So it's fascinating.
And constipated.
Progesterone likes to slow that motility down.
It's a smooth muscle relaxer. So it just makes your bowels move so slow. And this is why you might be bloated in the luteal phase.
Exactly.
Yeah. So that follicular phase in the first half is what is responsible for recruiting a follicle. And the follicles are basically competing with one another so that only one really dominates. And I like to use the analogy, I say this to my patients all the time. Imagine if you have 20 follicles. It's like having 20 people in a room and they're all starving, but there's only enough food for one person. They have to compete, and the person who wins the food gets to thrive, and the rest of them starve to death.
Oh, God.
And I know it's like a really kind of cruel analogy, but that's what happens in the ovaries. They're competing. These follicles all want to win, but
survival of the fittest. That's
one dominates, and that egg gets to grow. Meanwhile, the other eggs, they undergo programmed cell death, and they're gone forever. And so FSH is food for these follicles. It is needed to grow the follicle, and most of the estrogen in our body is actually coming from that growing follicle up until the point of ovulation.
Amazing. So much estrogen too. Yeah.
Yes.
It's beautiful.
And that's why I think most women feel energized. They have, like you said, that improved libido. Fun fact, the cervical mucus that you see is in response to estrogen. So if you're doing anything else that increases your estrogen levels, that is why you have cervical mucus. It's not actually because you're ovulating.
Exactly.
It's only because you have increased estrogen. A lot of people think the mucus means you're ovulating.
Right. Exactly.
But it's not an indication of what luteinizing hormone or LH is doing.
Right. Yeah. So those are things, that's a start to the picture of it. But right, something like, these advanced tech tools that we have now can really differentiate. Are you ovulating or are you not ovulating from cycle to cycle? And from the work that you do, how much ovulatory dysfunction that you see as a result of infertility.
Yeah. Number one cause of infertility is ovulatory dysfunction. So it's about, depending on the literature, 25 to 32% of infertility is because the woman's not ovulating. So quite a bit, 70% of that is from PCOS.
Yeah.
So super, super common. And the tough thing about PCOS particularly is that a lot of these women will use traditional ovulation predictor kits, the LH strips.
Yeah.
And it will remain positive because there's elevated LH it's chronically elevated.
Exactly.
And that is
it's
what's preventing.
Exactly.
It's what's preventing the recruitment of a follicle to eventually release an egg. And so that is what I like about the more advanced testing, where you can check to see what estrogen is, the estrogen levels, progesterone levels. That tells you so much and also helps you confirm ovulation.
Exactly. It can be super empowering. And that's what you need on a fertility journey, is just empowerment and a lot of education about what your specific body is doing. And that's really why I love Inito so much, is because, look, they're saying, it's not about the actual values on that chart. It's what have your trends been to get you to release an egg and to ovulate and to bring that PDG metabolite up. Yeah. And so from month to month, it's fascinating. I had a patient who I was following her charts, and she traveled to Spain, but she was still sending me her charts. And I was just like, what is going on? Like, you didn't have an LH surge, and then you didn't, have any progesterone metabolite rise like you did last month. And she said, it's been pretty crazy, like how much traveling has really impacted my sleep and my energy. Yeah. And you get to see those lifestyle modifications that really impact your fertility hormones.
Yeah. Today, I want to talk to you about a tool I personally recommend to my patients who are trying to conceive, Inito. Inito is the first at-home fertility monitor that tracks 4 key hormones: estrogen, LH, FSH, and PDG, using a single easy test strip. And in just 10 minutes, it gives you incredibly accurate hormone readings, but without the stress of lab visits. Inito can help you detect your fertile window with precision, predict ovulation reliably, and then confirm ovulation has occurred, giving you a complete understanding of your cycle. This comprehensive hormone tracking becomes particularly critical when we consider anovulation, which is the leading cause of infertility and often goes undetected. Inito serves as an indispensable tool here, not just for predicting ovulation, but more crucially for confirming it. It achieves this through a sustained rise in PDG, the urine metabolite of progesterone. As a physician, I trust the data Inito provides. I use it to monitor how my patients are responding to treatment, and I can adjust their plans in real time based on actual hormone levels. So if you're looking to take control of your fertility with clarity and confidence, I highly recommend Inito. Head over to Inito.com and use my code TTCPODCAST to get your starter pack for just $89. That's INITO.com. Absolutely. Now, as someone who is board certified in lifestyle medicine, are there any recommendations that you make to patients regarding specific nutritional changes throughout the menstrual cycle?
Absolutely. Yeah.
Teach me.
Yes. So, for things like if we're seeing, estrogen levels, too low or too high, we'll talk about, one, we want to figure out what is there to that, what's the diagnosis, is it PCOS? Is it diminished ovarian reserve? Is it premature ovarian failure? Is it premature menopause? What's going on? But at the basics, I see high estrogen levels. I talk to them about their gut health. Are you constipated? What are you eating? Are we making sure that we're eating good fiber intake, that we're doing cruciferous vegetables that help to metabolize your estrogen well? Low estrogen, we talk about, are you under eating? Do you have that base of healthy fats that, your body needs in order to make these hormones from cholesterol? So, and then just complete nutrition, what are you feeding your body? Are you on the go? Are you actually sitting to digest this food and to get the nutrients extracted from it that you need for fertility? Because your body is going to prioritize your health over adding another life to it if all you're feeding it is, 2 to-go meals a day, right? You really have to have that nutrient dense eating for your body's needs.
Which I think a lot of people lack.
A lot.
Yeah. It takes a lot of effort and planning, I will say, and that's the downside. But I do think that it is something that should always be prioritized in everybody's routine, but particularly if you're trying to conceive for both men and women. They really need to focus on the nutrients that they're getting. And I'm all about that.
Yeah.
The raw veggies and fruits, also cooked. You got to enjoy your meals too. But I'm all about the whole foods as much as possible. Are there specific ratios of, do you ever track macronutrients, like the amount of fat versus carbs versus protein?
We do we have an oxygen assessment test that we do for women that come into the clinic. And so it gives us a breakdown of, their heart rate variability, how well they're utilizing, oxygen, their metabolic flexibility. And then it also breaks down their macros based on their needs, their basal metabolic rate. And then, it's a beautiful test. And they just get to sit there and breathe oxygen for 10 minutes. So, but I don't harp on macronutrients, but it's more of just that, that enlightenment, like literally, look at this. This is what your body needs. And you're not eating even half of that. And it's always so intriguing for me. And I did this myself. I wasn't thinking about what I ate. Even in pregnancy, right? You're kind of given that validation. Oh, well, you're pregnant. You can eat whatever you want. I didn't think about what my child was eating until he or she were earthside, and I'm literally feeding it to them. Oh, well, I don't want them to have processed foods, but
here you were eating the processed food. I know. I did the same.
And that groundwork, if we lay it down earlier and earlier in that embryonic time period, we're going to have so much better outcomes for the health of our child that when we do finally have that baby.
Totally.
Yeah.
Yeah, it's. I think it's very underplayed because I hear a lot from patients and from friends and other guests who've been on this podcast who say, I've seen fertility specialists who've told me that your food really is not that big a deal. You either have good eggs or you don't have good eggs. You don't have to try that hard. Exercise doesn't matter. Nutrition doesn't matter. And when I hear that, I'm confused because I think, well, what? I don't think any medical society even says that. And I still think that the medical societies have a lot more work to do in terms of specific recommendations when it comes to lifestyle medicine.
100%.
It is often underplayed. I don't think that we stress enough that the daily habits that we do can impact. Obviously, some people are more susceptible than others, and it's really hard to predict your susceptibility to your lifestyle. So yes, we know that there are plenty of people who are super unhealthy and they have very predictable ovulatory cycles, really great fertility. They get pregnant without even trying. Yes, that is true. But on the other hand, there are many who are very unhealthy and they are struggling with their fertility, and oftentimes doing those lifestyle interventions alone will get them to baby without even pharmacotherapy.
Exactly. And that's where I love to be. That's the space that I love to be, where it's that hey, this is in your control. These are things that you can do. And hey, if you need IVF or, artificial insemination, these are tools that are only going to help that journey, optimize that for you, So there's such that connection, that full circle that finally comes back to, okay, these are things that are in my control. These are things that I can do. I can't control, the IVF stem cycle. I can't do anything about, that I have to be here for this ultrasound at this time. But I can control my mindset. I can control what I'm nourishing my body with. And just that, where it just doesn't even make common sense. If a woman goes through infertility, not being able to conceive for a year, that's a chronic condition, right? Diabetes, cardiovascular disease, Alzheimer's. We know that there is that association with lifestyle, with all of those chronic diseases. So it just doesn't even make common sense that we wouldn't associate lifestyle. And we've got the data to back it up too. There are plenty of evidence-based studies on this. So
yeah. Well, since we've been on the topic of lifestyle and nutrition, I do want to delve into, because I just saw one of your recent posts on Instagram about supplements. And so specifically on folic acid, which I loved that post because even as two people who care so much about lifestyle, we still also care about the data and what the evidence shows quite a bit. Yeah. And I think that in a sea of misinformation online, a lot of people are convinced that folic acid is not effective.
Yes.
And to give a little bit of background to anyone who doesn't really understand what we're talking about, 40% of both men and women in the population have what's called an MTHFR variant. A variant is what was previously known as a mutation, but we changed in the, Medical Genetics Society has changed mutation to variant because mutation sounds like it's always pathologic, but it isn't necessarily. So MTHFR is a polymorphism, meaning it is just a variation in the DNA nucleotide in a particular gene. And because it is present in 40% of the population in the genetics world, something that is that common does not have any clinical relevance. And a lot of people think that because they have the MTHFR mutation, they are either dealing with infertility or pregnancy loss, and therefore they have to have the methylated folate version in a prenatal in order to get that absorption. So what is your response to that?
Yeah, and that's where it's like, well, I'm either gonna believe the functional holistic world or I'm going to believe the conventional world. When it comes to the health of a growing fetus, we have to go on data. You can't just extrapolate that methylated folate is just as effective as folic acid if you don't actually have the data to back it up. And so 100%, hey, if it makes you feel better, do some methylated folate.
Yes.
But don't leave out the folic acid.
Agreed.
Do both. Please do both. Yeah. It's just not worth it. So,
yeah. And I've told patients, it probably doesn't make a difference, but we do have there are some pharmacology studies showing better absorption of folic acid, which, is I'm sure you get some heat from that online too, whenever you say that, where people expect you, especially someone who's doing integrative medicine, functional medicine, to say, yes, folic acid is inferior, but that's just not true. It's not true.
No.
Yeah, I love that.
Exactly. And that's where that's where not enough doctors or providers or practitioners or influencers, that's not where they're at. They're not, you have to be humble. If you're taking care of a life or two lives, you have to be humble enough to say, you know what, I was wrong. That's not the case. Don't die on that hill, because that's having such a huge ripple effect on the impact of people's lives, truly.
Yeah. And I've seen neural tube defects arise from patients not taking folic acid, and it's pretty devastating. Yeah. It's just, it's a loss that didn't need to happen.
Exactly.
Yeah. So let's talk about how are the best ways to track ovulation? Because I think that this can be a pretty overwhelming process for many women. I think that there are women out there who are incredibly well-versed, but it seems that, and at least in my patient population, you might be seeing the same thing, the majority are exclusively using the calendar method. Which, listen, I'm all for using it as a part of your ovulation induction. I also think that using an app is helpful to keep track of everything. If you need that just to look at a calendar to help predict future cycles. But my biggest issue with the calendar method only is that it is assuming that, let's say you have a 30-day cycle, that it's a 30-day cycle every cycle.
Exactly.
And that you absolutely have a 14-day luteal phase. Yeah. So 30 minus 14 means that you ovulate on day 16. Or you can use a more traditional 28-day cycle to make it easier. 28 minus 14 is a 14-day cycle, day 14 ovulation. But then the calendar method is saying that next menstrual cycle, you will ovulate on cycle day 14 or 16.
Exactly.
And that there is no variability. But the reality is
there's variability
from cycle to cycle.
Absolutely. Yeah. And then so when you have, women are waiting later and later to start their families. And we know that every month we have a 25% chance of conceiving. But the older that we get, that percent chance reduces. I had a patient the other day that came in. She chat GPT'd if she's this old and she's trying for pregnancy with an AMH of this level, what are her chances of getting pregnant each month? And she just came in devastated because ChatGPT had told her it was like a 5% chance each month. And so, if you're going to get that information from ChatGPT, right, you better have some tools in place to do something about it. And so that's why I love, going beyond just the calendar and tracking your actual cycles to get a full 6-day fertile window instead of just that 1 or 2 days of having sex, and you still may be missing that fertile window because if you have a 32 or 34-day cycle when last cycles you were 28 days, there's that disconnect. You're just not getting those fertile windows to have sex.
Totally.
So, yeah.
Yes. Yeah. And the fertile window ends on the day of ovulation.
Exactly.
So if you're having sex after you ovulated, the chance of conception is extremely low.
Yes.
And in fact, we know that peak fertility really happens 2 to 3 days before you even ovulate.
You got it. Exactly.
Yeah.
Yeah.
So in addition to a calendar method to track your cycles, what else do you recommend in terms of tracking?
Yeah, I say that the basal body temperature is, if someone comes in and they're adamant they did the basal body temperature for their first pregnancy, hey, I'm supportive. Sure, let's go for it. But, you understand that this is just telling you that it maybe confirms that you ovulated. Even a rise in basal body temperature, still some months you may get that, but you may not have released enough progesterone to get that sustained rise. And so that's something that then you need to track. You need to look back retrospectively and say, okay, my basal body temperature rose on this day, which means that I need to have sex a few days before that day, or even, a week before that day. So that's, for me, is not the best tool.
Agreed.
Most women are not going to walk around with their basal body temperature or do it exactly at the time that it has to be done in the morning. And then we're all traveling. We're all busy, I do love, my ring for, checking my basal body temperature. Yeah. And then cervical mucus, I personally love when patients can get an idea of what's going on with their body, like just even touching themselves and understanding what's going on with their bodies from day to day. But just like you said, it's not the best tool for ovulation and confirming that you actually ovulated. And we know that, women are going to have anovulatory cycles, it's just going to happen. It's happened to me before. Whenever I was super stressed in medical school, I was having anovulatory cycles. But sometimes it's not so obvious as, oh, you missed a period, or your period was late, or your period came early, and therefore, you can best be reassured that you didn't ovulate. Sometimes you can still have a flow, right? You can have a period even when you didn't ovulate. So tech has entered the text message chain for infertility, for fertility. And so I think that it's amazing that we're finally have some women's health tools that are going to help us to achieve our goals sooner.
Yeah, absolutely. And I want to harp on the fact that some cycles are anovulatory. You may have a period, but may not have released an egg. The most high yield example of this is in PCOS.
Yes.
So a lot of women will come in saying, well, I had a period 2 weeks ago, and prior to that, I had a period 5 weeks before then. And so my ovulation is just sort of irregular. But what we do know about PCOS specifically is that sometimes your lining overgrows the blood supply.
Exactly.
And so the shedding is actually not from a progesterone withdrawal because you did not release an egg.
Yeah.
There was no ovulation. There was no rise in progesterone, or I should say rise and fall, that made you bleed. It's just that the lining, you have unopposed estrogen, which I kind of hate when people on Instagram or on social media use the word estrogen dominance. And so I know it's like the goal is a simplified version of saying that, but the true medical term is unopposed estrogen, meaning you're getting estrogen chronically and you're not getting progesterone with that.
Exactly.
Estrogen, what it does is it builds the lining of the uterus. It keeps getting thicker and thicker.
Yes.
But as it overgrows its blood supply, it just starts to shed. And that shedding can be totally sporadic, where you bleed. And then 3 weeks later, you have another bleed. And that bleeding may last a lot longer. And which, by the way, bleeding more than 7 days is not considered normal. And so if you have a period that lasts longer than a week, that needs to be checked out. And so if you don't have the proper tools, like checking your hormone levels, checking to confirm there is a rise in progesterone, you may think that you're having ovulatory cycles, but they're totally anovulatory.
Exactly.
Yeah.
Yeah. So PDG metabolite from Inito, that's your ticket, to see that. Now, I have done, my own little research on, and I know that you're always checking blood progesterone levels.
Always.
But I have seen the correlation with it's about 1.5 to 2-fold from the PDG metabolite levels and what I see in the blood, because I tend to still tell patients, look, for something as important, especially, like luteal phase deficiency, I want to get a good idea of your blood hormone levels, as we're going through this. So it's fascinating to see that I'm seeing that correlation, and I can give patients that confidence.
That's amazing. Yeah. I don't think I've ever really done both at the same time. And now I'm kind of curious to try it out, because usually one thing I do really like about Inito is that I will have my patients send me their charts.
Yeah.
And so especially because I have patients who live really far away, some of them are a 4-hour drive away, I just have them send that instead of driving over to get their monitoring, get their blood tests. And it's really helped to sort of plan the priming before their IVF cycle or do the ovulation induction in order to sort of decrease the cost of monitoring in preparation for insemination. And it's worked really well. It's worked really well. So it's really cool that you've done that correlation and seen how accurate that is.
Yeah.
So I want to transition into, if someone is using the Inito device, they're tracking their hormones and things are a little bit off. They're realizing that maybe they have a really short-lived LH surge, or it's not peaking as they thought they would, or maybe they did have an LH surge, but progesterone isn't really rising. What are the things that you tell patients, okay, these are abnormalities in your Inito, and now you need to go see a doctor, or you need to, I guess they're already seeing a doctor, they're seeing you, but what would you recommend to the general population as a possible red flag in their Inito monitoring that they need to get checked out?
Yeah. So I think some big ones are, seeing a continued rise in FSH in the follicular phase. Like it's just staying high. Estrogen is not coming up appropriately. And of course, I do prelim evaluation and get, hormone testing, days 1 through 3, FSH and estrogen. But right, that's changing month to month. So if we're seeing that pattern of likely, diminished ovarian reserve, poor egg quality, that's when we say, okay, I think let's work together, but let's get you to an RE sooner than later so that we can make sure that your timeline is such that you want to stay on that timeline,
Totally.
And then for that PDG metabolite to not see it rise, we know that there's so many lifestyle factors around, ovulating or not ovulating, and stress is a big part of that. I think when I sit down with women and they have that even history of anovulatory cycles, 9 times out of 10, they're saying they work for, a very stressful, toxic work environment. They're traveling all the time. And as much as, right, we don't want to put blame on women. We don't want to say, well, if you didn't work as much, maybe you would ovulate. But it's trying to get them to see how that all is interconnected, okay? Can you talk to your manager about your workload? Can you advocate for yourself during this time? Can you be honest with your boss and let them know about what you're going through and that maybe you just need some days to work from home, And thankfully, that's what we're starting to really see in workplace policy changes, around fertility and that trying to conceive journey.
Much needed.
Yes. It truly takes a village. Before you even have a child, it takes a village to have a baby.
I know everyone talks about the village that's needed once you have a baby.
Yes.
Nobody talks about the village that's needed to get to baby.
Right. Yeah. Yes. Yeah. And then that PDG metabolite. So following that, knowing that, we may see, some fluctuations here and there, but we shouldn't see it, tank, right? And at that cycle, we may not be able to do anything for supporting progesterone at that time that may be meaningful for that specific cycle, but we sure can prepare for the next cycle, And so I think that understanding that luteal phase deficiency is multifaceted. We still don't know a whole lot on it. And that we also have women with progesterone intolerance. I don't know if you see this with using the Inito, but some women that are doing oral progesterone, I don't see as big of a increase in their PDG metabolites. And
it is not very bioavailable, which is actually why we rarely, pretty much almost never give it.
There you go.
As REs.
There you go.
The only type of oral form that should really be given is sublingual. So that does have better absorption, but I usually have them place the oral tablet vaginally.
Yes. Yeah. And patients are so averse to that, but it's
just wait, what do you mean? You take the pill and you shove it up there? And I'm like, pretty much.
Right, exactly.
The biggest side effect is the discharge. So, get some panty liners. Been there, done that.
Been there, done that, yeah. So. And the creams, the wild yams, those aren't going to cut it at all. No. Don't even go there with that.
No. Absolutely. And then the other really interesting thing, so you talked about FSH and estradiol, but I don't think a lot of people understand why that matters so much in the beginning of the menstrual cycle. When you first start your period, your FSH and estradiol level should be low. And that's just because you haven't really started the process of follicle recruitment. Yeah. But what's really cool is if you start tracking before your period and you see that your FSH is already high, that is an indication that you're actually starting to run out of eggs. That the ovarian depletion has commenced, because we see that in perimenopause, where there is very little eggs remaining, and I on average, it's about 10,000 eggs at the time of menopause. So people think it's zero, but it's not zero. But still, that ovarian reserve is getting depleted. And so the brain is going a little haywire. And prematurely secreting FSH. You can still see this in young women who have a lower AMH level. And it's not that AMH necessarily correlates to the likelihood of pregnancy, because in a menstrual cycle, we're typically just releasing one egg at a time.
Right.
AMH does influence IVF success, however, particularly depending on female age and how low it is. But it's really neat that you could already get that insight into your body. And like you said, I love it when patients love when they're so in tune with their bodies that they, some patients are lucky enough that they say, I feel when I ovulate, it hurts, it sucks, but I know exactly when it's happening.
Right.
I know exactly the texture of my cervical mucus as I'm preparing for ovulation. I know what it feels like when my progesterone is peaking. And when you are tracking your hormone levels over time, if you even, for instance, journal what your symptoms are, then you really start to understand your body in a way more intimate way.
Exactly.
That I think it's a way to even start to love your body more.
Absolutely. Yeah. And that just goes back to like even just teaching about the menstrual cycles at a young age, like let's start learning about our bodies more. Like you shouldn't know more about, the Kardashians' body than you should know about your own body, and then erasing that fear. Just like you said, if you see your FSH rising towards the end of one cycle going into the next cycle, well, don't make decisions based out of fear. Take that as, gosh, this is amazing that I get to see this now and do something about it now. And I have access to amazing interventions like IVF and like artificial insemination to get me where I want to be, because there is no woman who truly wants to be a mother that it's not going to happen with commitment, determination, the right team.
Totally.
Yeah.
I love that.
Yeah, it's true.
Well, Dr. Pero, it was so lovely having you on.
Thank you, Sasha.
I love this conversation. And this is great. Yeah.
Thanks.